All right, we're going to talk just real briefly about the metabolic endocrine emergencies and the medications that we might use in those situations. Now, a lot of this might be review for you because we've talked about diabetes a lot in your EMT training. So this will be a good review, and then we're going to add in some of those medications that we might give in the pre-hospital or hospital setting. So what we're going to do is we're going to define what a hormone is, and we're going to talk about the pancreas and what it does and where we can find it. We're going to talk about glucagon, a medication that we can give, as well as a natural hormone that's produced in the body. We're going to talk about diabetes mellitus and talk about what it is for sure. We're going to discuss the function that insulin plays with glucose in our metabolism. We're going to talk about type 1 and type 2 diabetes, and you will be able to know the difference when we get done. We're going to talk about the differences between diabetic ketoacidosis, hypoglycemia, and HHC. We'll talk about those in just one second. And we're going to describe and talk about the indications, contraindications, and dosages for our drugs in these situations, which would be D50, glucagon, thiamine, and insulin. Okay. So let's talk a little bit about diabetes. Hormone is a chemical substance that's produced by an organ or specialized cells in our body that regulate the activities of another organ. And probably the pancreas and our insulin is the crown jewel when we talk about hormones, because this plays a very important role here. Now, the particular hormone that we're going to talk about is actually created in the pancreas, and the pancreas is located in the retroperitoneal area. And that retroperitoneal area it's in the abdomen, but it's against the back wall of the abdomen. So it's on the back side, kind of back against the spine, and the intestines are in front and around that. So it's very protected by the intestines, and it sits and snuggles right back in there. Here's a little picture of, simplified picture of the pancreas. So you can see here in the middle we've got these little, we've got delta cells and beta cells, and over here we've got an alpha cell. And then we've also got small little sites that are called islets of Langerhans. And islets of Langerhans is actually what produces the insulin in the pancreas. So I don't know, I like to say that. It's cool, sounds Irish, but islets of Langerhans is actually what produces the insulin inside the pancreas. So it produces insulin from the beta cells that are located there. Okay. It produces glucagon from the alpha cells that are located there. And we're going to talk about what glucagon is. And then the delta cells that are located in the pancreas produce somatostatin. And the somatostatin is a peptide hormone that regulates the endocrine system and deals with neurotransmission. And the glucagon is a peptide hormone, and it helps increase the concentration of sugar in our bloodstream. So insulin, we talked about last week when we talked about facilitated diffusion. Facilitated diffusion is when a protein molecule moves across the cell wall with the help of another protein molecule. So the glucose is needed by the cell, and the cell has to have the glucose to create energy. But the glucose itself cannot enter that cell, but when it binds with an insulin hormone, then that insulin hormone kind of opens the door so the glucose can get in the cell. Now, glucagon takes those stored carbohydrates that our liver stores and breaks those down into glucose and puts those into the bloodstream. It also, well, we'll talk about what it does in a minute, but so it pulls out that reserve, that backup reserve that the liver has, pulls it out, puts it into the bloodstream. Now, once glucagon has gone into the system and pulled those reserves out, we have no backup plan. We have depleted absolutely our last bit of glucose within the body, so we have to keep that in mind when we're dealing with glucagon. And now diabetes mellitus is the correct term for this, is caused by a defect either in the insulin secretion or the effects of insulin on the body, or possibly both of those. So type 1 diabetes, I can remember type 1 is the type that requires insulin injections because the type 1, the 1 looks long and tall and looks kind of like a needle. Whereas type 2, the number 2 does not. So type 1 is actually insulin-dependent diabetes. So our pancreatic beta cells have been destroyed or are no longer effective, so our body is not producing any insulin, or so very little that it doesn't even matter. Sometimes this is caused by viral illnesses. Oftentimes our autoimmune system has been weakened or destroyed by our lifestyle. So by eating the wrong foods, by being obese, by having lack of exercise, and then our genetics, of course, all put us at higher risk for contracting type 1 diabetes. Type 1 diabetes is almost always diagnosed, not always, but more frequently probably diagnosed in childhood. And so children ages 3, 4, 5, 6, 7 may be diagnosed with this. Treatment is lifelong daily insulin injections. Type 2 diabetes is more common, usually as an adult onset, sometimes later in life onset. And the pancreas is still producing some insulin, but it's just not very responsive. When the blood sugar levels go up, that should, under normal circumstances, stimulate the pancreas to produce more insulin. In these folks' case, that's not quite that sensitive, and so the blood sugar levels can go way up before insulin gets produced. So this is frequently managed with diet and exercise and sometimes oral medications. Glucophage is a very common and popular one that's given to patients with type 2 diabetes. Usually they're not required insulin unless they get really, really high, but they are more prone to a situation called hyperosmolar hyperglycemic coma. So this is a coma that kind of comes on slow onset. It's not super high sugars, whereas DKA, diabetic ketoacidosis, has very high sugars. So we'll talk about those. DKA, the insulin levels go down, the blood sugar goes up, but because there's no insulin whatsoever, those individual cells become completely glucose depleted. Whereas our patients that have type 2 diabetes, there is a little bit insulin there, so it kind of keeps those cells from being completely depleted. Our body, because we have so much sugar running around and no way to use it, starts to try and metabolize this sugar. And it does that in several ways. And when we try to metabolize this, sometimes we try and metabolize it through the kidneys, and in that case they can take a sample of urine and dip a little strip in and test for ketones. When ketones are present, that tells you that your sugar levels are probably high because your body is trying to metabolize them through the kidneys. We also can try and metabolize them through the respiratory system and try and breathe out that sugar. And so neither one of these are very effective means of metabolizing that sugar. So if we have a patient that's in DKA, they will probably have very, very high sugars. And if not corrected quickly, they can go into a coma, and at that stage they're very much in danger for death. So hypoglycemia, and you hear this called insulin shock sometimes, because they're low blood sugar. Usually this is a rapid onset, where our hyperglycemia, where our sugars are high, is generally a slow onset. And usually getting a history is going to kind of give you a pretty good idea of which one you're dealing with. So insulin levels decrease, or insulin levels increase, blood glucose decreases, and with that low blood glucose, then we can damage our cerebral cells or our brain cells pretty quickly. Generally, this is caused by people that either take too much insulin and don't eat enough, or take their insulin and regular diet, but they are burning that sugar up quicker than normal. In kids, this is really easy to get to because their metabolism is so fast, it's very hard to stay on top of this and keep it balanced. Okay. So some things, and this is probably a review for you guys, but we'll go through it anyway. People with hypoglycemia, like we said, it's going to be a sudden onset. They generally kind of get irritable, kind of cranky. They may get pale. They may be hungry, thirsty. They may be a little bit weak, uncoordinated. A lot of times they appear intoxicated. They can move on to become very combative and nasty, uncoordinated, and can go into a coma. Cold, clammy skin, sometimes diaphoresis. And so we want to check these blood sugars in these patients quickly. Oftentimes, these people either look intoxicated, and frequently blood glucose levels that are low can be confused with a patient who's had a stroke. Now, people with high blood sugars, hyperglycemia, you're going to see these patients, like we say again, this is a gradual onset, but what you're going to notice is these patients eat, drink, and pee a lot. And they're trying this, the body is trying to pee out the ketones, and you may see these people with rapid, deep respirations because they're trying to breathe out the sugar. You also may smell a fruity or kind of an acetone smell on their breath because they're trying to breathe out the sugar. They can be tachycardic. Usually these people aren't pale and diaphoretic. They have warm, dry skin. Oftentimes it's pink. But they're going to be very thirsty and very hungry because the cells aren't getting the sugar. They're sending a message to the brain saying we're not getting any sugar, so the brain's like, oh, we probably need to eat some more. So it increases the hunger, and they're peeing out a lot of sugar, and their kidneys are in high gear trying to pee out all the sugar, so the body does become dehydrated, and therefore it makes them thirsty. So oftentimes these patients have a history of diabetes. Sometimes they don't. And sometimes you catch new onset diabetes when we get called to this. Generally people that are hypoglycemic, have low blood sugar, that's not when we catch their blood sugars, because when they first get diabetes and they're not trying to control it with meds or insulin, their blood sugars get high. So we find them, new onset diabetes, present with this hyperglycemia. So in the field, we're probably going to start with fluids, quite a bit of fluids with them, because oftentimes these patients are dehydrated because they've been peeing so much. On occasion, we may be able to give insulin to these patients. Generally in the field, we do not, but there are times when it's appropriate. So let's talk about insulin. There's 3 different types: the rapid, the intermediate, and the short acting, and those are just different time frames, how quickly they act and how long they stay active in the body. Insulin is a hormone, and you may hear it called an anti-hyperglycemic, which only makes sense, that it's something that goes against high blood sugar. In diabetes, we're not capable of producing adequate amount of insulin, so this is just a supplemental insulin. Some insulin is actually produced from pigs, and that works well for some people, but some people develop kind of a resistance to it, and it doesn't work so much. And so they then go to a genetically engineered or a synthetic insulin. And you see this a lot with our patients that we deal with that are known diabetics. And the two general names we're going to see with that brand names are Humulin and Novolin. And so we'll talk about those. Both of these drugs, both types, combine with insulin receptors. So that's the receptors on the cell that kind of open the door and let the glucose in. And once the glucose goes into the cell and is used to produce energy, then our blood sugars drop. So you can see here from this chart, this is in your textbook, so I'm not going to spend a lot of time going over it, but the rapid acting is less than 15 minutes. Then we have our short acting, which takes a half hour to an hour to take effect, but maybe lasts up to 8 hours. Then we have our intermediate acting, which takes 2 to 4 hours to take effect, but you can see here it may last up to 10 to 18 hours. And then we have our long-acting, which is the Lantus and the Levemir, which are fairly new. In the last 10 years or so, those have come on the market. And they take a few hours to take effect, but can last up to 24 hours. Now, some of the meds, like Humulin or Novolin, 70-30 is a combination of those. So when you get that combination, it acts quickly but lasts long, and that's kind of a nice combination for some of our patients. Okay. So to give insulin, we're going to have somebody that's probably hyperglycemic, potential, and maybe even in diabetic ketoacidosis, or somebody that is hyperkalemic, so they have a high calcium count, in which case giving insulin and then D50 kind of reverses that hyperglycemia. And it's weird and it doesn't make sense, but it works. Contraindications. We are not going to give this to a patient unless we absolutely know that they have high blood sugar. Giving insulin to somebody with normal blood sugar can be fatal. So not generally, not in the pre-hospital phase, but on occasion you may find a situation where it's appropriate. Okay. We're going to monitor the blood glucose carefully and be ready to treat for hypoglycemia. Once we give the insulin, they can burn that sugar up so quickly that they become hypoglycemic very quickly. At the site, we may get itching, swelling, redness, but generally there's not a whole lot of side effects other than it may drop their sugar too quickly. Okay. Interactions, if our patient is under a lot of stress or is very anxious or having some steroid use, that can increase the blood glucose level, in which case we may take a little more insulin than normal to bring the blood sugars back to a normal level. And patients that take beta blocker medications may kind of mask their signs of hypoglycemia. So you may not see those quick onset signs of irritability, confusion, all of that in somebody that takes beta blockers as quickly as you would in another person. Okay. So if our patient's in a diabetic coma, they're unresponsive, probably 5 to 10 units of regular insulin. Again, you're going to give this under medical direction. And generally, patients that take insulin have a scale that if their insulin is between this level and this level, then you give this much insulin. And it's all marked out. We can give 5 to 20 units of regular insulin, subcutaneous or IM, if patient is not in extreme danger. Obviously, subcutaneous is going to be a very slow onset. IM, a little faster than subcutaneous, but much slower than IV. But if they're not in extremes, we probably aren't going to be giving this in the field. Okay. Now, glucagon is a medication that we can give in the field, and oftentimes family members of diabetic patients have this on hand in case they get into a hypoglycemic crisis. So, as we talked about, glucagon is a peptide hormone that's produced in the pancreas. We're going to give this hormone as well, and so it's used to increase blood sugars. And we talked about it, goes into the liver and releases those storage of glycogen, which is stored in the liver, which is a carbohydrate form, and transforms that into glucose that can be used by the body. So it can be administered IM. I see that it says in several different places to consider the use of IO for rapid access. But quite honestly, if you've got an IO in place, your better medication is going to be D50. Just get that simple sugar in and use it. Because if you give glucagon, it's going to completely deplete every ounce of sugar that we have reserved in our body. And you're banking on the fact that there is a reserve there. If the body has already used that reserve, then the glucagon is not going to be effective. So D50 is going to be your better choice if you have an IV. If you don't, we can try the glucagon IM in hopes that the patient will rouse around enough that you can get some oral glucose in them or some fluid to get an IV to give some D50 via IV. So it takes that glycogen and converts it to glucose. And then it also inhibits the conversion of glucose back into the glycogen form to be stored. So the blood sugar levels do come up, provided we've got that storage. It takes 5 to 20 minutes for that to happen. We get the peak effect in about 30 minutes, and it continues to last for about 1.5 hours, at which time any glucose in the body could potentially be converted back to glycogen and go back into storage. So it's not a quick onset, but it's certainly better than the nothing we're going to have if you don't have IV access. Okay. So in low blood sugar patients and in patients that have a beta blocker overdose, we're going to consider giving glucagon. Okay. Some patients are hypersensitive to it. It's a normal produced hormone, so very few patients actually really have an allergy or a hypersensitivity to this. Okay. Again, we talked about the drug of choice is D50 for a hypoglycemic patient. Okay. If we've got a patient that's got cardiovascular disease or renal disease, we want to make sure that we have our ducks in a row with this, because it can be somewhat destructive to those systems if they're already impaired. We can get hypotension with this, dizziness, headache, nausea, and vomiting. And if our patient is in a hypoglycemic crisis, there's really few interactions that we need to worry about. Standard dose for this drug is going to be 1/4 to 1/2 units. We measure this in units rather than milligrams or milliliters. And that's going to be IV push, like I say, if you have an IV. But if you have an IV, give the D50. If you don't have an IV, this is where glucagon kicks in. Then you can give the 1 milligram IM. Inject it right into the muscle. Like we said, it's going to be that 5 to 20 minute onset. And then hopefully we can get more sugar on board to get these patients up and around. Okay. Now D50. This is our wonder drug. I love giving this stuff because it truly takes a really bad situation and makes it just okay. It is a carbohydrate. So it is sugar. It is something, a carbohydrate is something our body can convert into sugar to be used for energy. And it is our principal carbohydrate used by the body. So it is the simplest form of sugar. It's the type of sugar that our brain can use. So in cases of hypoglycemia, we're going to give this because brain damage occurs when our brain cells are low in sugar. So we want to get this turned around as quickly as possible. Onset of this is generally less than a minute. You get a good patent IV, you push it, and literally within seconds your patient wakes up. And if you haven't seen it, you need to. It's very cool. If we have a coma of unknown origin and we don't know why our patient's in a coma, it is okay to administer D50. It just helps you rule out. If your patient is hyperglycemic, they're not going to give enough to really make them that much more, but it certainly could be life-saving if they're hyperglycemic or hypoglycemic, low blood sugar. Really no contraindications. If we have a patient that has increased intracranial pressure, or the pressure in their head is building, maybe with a head injury or something like that, we may want to be very cautious and give smaller doses, or see if we can get that patient to eat as opposed to getting the D50, because that can make that swelling in the brain worse. Absolutely, we have to have a patent IV site to give this drug. So we're going to check a blood glucose level. If it's in your protocols to give a sample of blood beforehand to be tested, that's fine. In an emergency state, I don't know how important that is. So we're going to look at what our blood sugar reading is, what the state of our mental status of our patient is, and use those things to determine how much we're going to give. Now, we want to get a nice, good-sized vein. Smaller veins may blow, and if you blow the vein or the D50 gets outside the vein into those tissues, it's very necrotic. These are two pictures of necrosis that has happened because of dextrose that got outside a vein into the tissue. Can cause permanent damage, but my goodness. And patients that are diabetic heal so slowly anyway, this can be extremely excruciating. So make double, triple sure you've got a good IV. That being said, we'd like to start an 18 gauge if at all possible. Pushing D50 is like trying to push K-Row syrup through a needle. It's very thick and hard to push. So if we get a bigger needle, it's going to flow easier. But we need to have an adequate size vein to make sure that we don't put so much pressure on those vein walls that they rupture and that drug then goes out into the tissues. So it can be pushed through a 20 gauge. If that's all you can get, you just have to understand that it's going to be a little slower process, and you need to be a little gentler with that because you're going to have a smaller vein to use. So no interactions. Our standard dose is 25 grams. It's a full ampule. It's 50 ml, so it's a big syringe of sugar water, and that's basically, it's very sticky. It's very it's thicker than most that you're going to give, and that's IV push. In some cases, we may give 12.5 grams, a half a syringe of that, but for the most part, we're going to give the whole thing. And then if our patient doesn't respond, we can give a second one. If they're very, very low, sometimes it takes a couple to get them up and running. When you give this to your pediatric patients, we're going to give what we call D25. So it's dextrose 25% in water as opposed to D50 dextrose 50% in water. So to make this, we're just going to dilute it half and half with water, with sterile water. Dilute it down. That makes it a little thinner. It's not nearly as necrotic on our little guy's veins. And then we're going to dose that out at 1/2 to 1 gram per kilogram. So, and we'll give that nice slow IV push. So just keep in mind, with our tiny, tiny babies, we're going to go even less. So if we've got a newborn that we're giving is hypoglycemic and we're going to give sugar, we're going to dilute that down even more, and we're going to go dextrose 10% with those little guys. Okay, thiamine, actually you probably all know about this, is a vitamin, and the vitamin is vitamin B1. And what thiamine does in our system is it converts pyruvic acid to something called acetyl coenzyme A. And our cells use that acetyl coenzyme A to produce energy within the cell. So it's used in the metabolism process. And when we don't have B1, then those cells are not able to metabolize like they would normally. So without any thiamine, the glucose can't be used efficiently by vital organs, one of those vital organs being the brain. So chronic alcohol intake or alcoholism interferes with the absorption, the intake, and the use of thiamine. It makes that thiamine kind of ineffective in our system, which then, by process of default, starts messing with our metabolism in our brain and the way we process the pyruvic acid in our body. So a syndrome that you may hear about is Wernicke's encephalopathy, or it may be called Wernicke-Korsakoff syndrome. But and it's actually two syndromes that coexist. So the first symptom that you'll get with these alcoholic patients that have this inability to absorb thiamine is this cerebral pathology called Wernicke's encephalopathy. And frequently the symptoms of this obviously are going to be the alcohol intake, but you're going to see this kind of present when your patients are going through alcohol withdrawals. They've either not been able to drink for a period of time, or maybe they're trying to quit, and their body has become very dependent on the alcohol. And when we drop that alcohol level below the norm, it causes the brain to malfunction. We see this syndrome kick in because of the deficiency in thiamine, or the deficiency in vitamin B1. So you will see confusion, you'll see lack of coordination, you may see leg tremors, muscle tremors, double vision with these patients, and sometimes they develop a twitching in the eyes, and we call that nystagmus, where the eyes will twitch back and forth. So when the patients kind of get through this kind of passes, and then the Korsakoff psychosis will come in. Sometimes these actually coexist together, but they always are partnered with one another. The Wernicke encephalopathy is reversible. If we can get vitamin B in that, get them off the alcohol, get them nourished, because these alcoholics tend to become malnourished because of the whole thiamine issue. Their body can't use the pyruvic acid in the energy production, so they become malnourished. At this stage, in the Wernicke stage, it's reversible. Once we get to the Korsakoff stage, oftentimes it is not. And so what we see there is a lot of memory loss. They make up stories. They may have hallucinations. And recognizing this in your patients is going to be crucial to understanding that you need to give thiamine. So when we give thiamine, it's a rapid onset. We can give it in patients that are comatose of unknown origin, especially if alcohol is involved or if they have a history of alcohol abuse. Always in these patients, we're going to give it before we give D50. If we dump a bunch of D50 into their system and they are chronically low in thiamine, it can cause severe brain swelling and can actually be very fatal. And so not in everybody that low blood sugar needs thiamine, but if you're picking up the same guy that you have picked up before and he always smells of alcohol, or you have a history, a family history, or you suspect based on his lifestyle, the smells on or about him, or what people are telling you, putting a little thiamine in before you give the D50 is going to be potentially a very smart move. So no contraindications. We're going to look at our assessment findings on our blood glucose level to determine when and if we need it. Rarely do we get hypotension or respiratory issues. And other side, there's really no side effects of this. And no interactions. So we're going to give 100 milligrams IV push. So if you've got an IV, push the thiamine, flush it in good, and then pop in there with your D50. If you don't have an IV, then we may be giving the glucagon. And so if that case, we can give an IM injection of the thiamine and then follow that up with an IM injection of the glucagon to hopefully get that blood sugar level up. Alrighty, that is it for tonight. I hope this helped a little bit, and hope you guys have a great rest of your day.